Everyone, to the SADS Foundation's Healthcare Professional webinar on return to play for patients with genetic heart disease predisposing to sudden death. I'm Marcia Baker, the Program Director for the SADS Foundation. We are honored tonight to have Dr. Michael Ackerman, who is volunteering his time and expertise tonight. Dr. Ackerman is a genetic cardiologist and director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and Windland Smith Rice Sudden Death Genomics Laboratory in Rochester, Minnesota. He also serves as president of the SADS Foundation Board of Directors. Following his presentation, you may post your question in the chat, and he'll address those after his presentation. Or if you prefer, you may raise your hand and ask your question verbally. So thank you again, Dr. Ackerman, for volunteering your time tonight for the SADS Foundation. And now I'll turn this over to you.
Great. Thanks, Marcia. And it's a pleasure to do this with you and to partner with you and to serve as president of the board of the Sudden Arrhythmia Death Syndrome Foundation now these many years since 2006. And I appreciate you, Marcia, and your role as sort of our czar of education of not just physicians, which is the focus of tonight, but also patients and families and the entire comprehensive chain of all along the way. So appreciate you, Marcia, and the team, and Aaron. And I know, Aaron, there's about 60 to 100 yet to come on in. And so they're either coming on in and they'll be joining us, or they're going to be watching it when it's posted to the various YouTube channels and so forth. So we have another one coming in. So we'll just get our evening party started. I'm planning on about a 20 to 25 minute monologue, so you can set your clocks to that. And then we'll have a conversation for the balance of the time until we bring ourselves to the bottom of the next hour. So I will just share my screen here and have Marcia give me the indicator that
looks good, Mike. Yes.
Great. So return to play, or RTP, for athletes with cardiac conditions or genetic heart diseases that predispose to sudden cardiac death, or SCD. That's the topic for the next 20 to 25 minutes. These are my conflicts of interest to disclose. I don't think they're going to affect our ability to communicate this topic well together, but you can be judge and jury of that, because the this well together are the twofold learning objectives. And that is, first, we'll assess the past and present so-called expert opinion guidelines that have guided us in North America and Europe and down under regarding the whole topic of competitive sports participation for athletes who have a heart condition like a genetic heart disease. And then we'll turn and focus on an examination of the outcomes of my athletes, of athletes who own defibrillators, and of elite athletes who have returned to play, and show that we are developing data, not just philosophy, that can guide this deliberation of whether a patient can or cannot, should or should not RTP, return to play. So I want to get a frame of reference for you to think about and set the stage for this conversation. So would you personally, in your profession, in your practice, allow an athlete who has a sudden cardiac death predisposing genetic heart disease? And for now, that can be anything in the alphabet soup of GHD, whether it's ARVC, LQTS, CPVT, HCM, RESPECT, whatever that disease category is. And that person has experienced a prior on-the-field syncope, fainted. And that faint occurred while undiagnosed and therefore untreated. Would you then allow them, him or her, to return to their sport of choice? Do you find yourself wired as, yes, I would. I think it would be possible. No way. What are you talking about? Or maybe. And depending on where you find yourselves, then maybe I can help you evolve towards a yes. If you're already a yes, then maybe I can give you a reason to pause and do a self-reflection as to, am I the right person to be the yes vote or the enabler, the facilitator for the return to play? And if you're locked in, no, I wouldn't. Next question, you're disqualified. Why is that your predisposition, and challenge you to think afresh of it. Because if you've been no, you used to be in guidelines. Now, if you are a no, you're actually practicing contrary to the evolved guidelines. Now, they have evolved. 30 years ago, the guidelines were, and kind of still are for many cardiologists throughout the world, if in doubt, kick them out. You have a genetic heart disease, I don't care its name, I don't care its status, I don't care your treatment. You will not be doing competitive sports with that physician's blessing or facilitation. If in doubt, kick them out. We cracked the door open a little bit in 2005 with the adjustment. Unless your heart is perfect or the syndrome is confined to just your genome, genotype positive, phenotype negative, then no competitive sports. For the rest of you, we'll offer you a little bone and let you do class 1A sports. And then the change really happened 8 years ago when we introduced into the guidelines this language. After you have been well evaluated, well risk stratified, well treated, and well informed by the appropriate informer, return to play may be possible. Class 2, class 2B type language. How did we go from if in doubt, kick them out to yes, let's talk about it, maybe it's possible? In other words, shared decision making has made its way to sports cardiology, which is a concept that we introduced now 6-7 years ago, and we've created this paradigm shift. How did it happen? Well, not singularly, but significantly, Mayo Clinic is at the start and the reason for it, meaning not just a philosophy, but developing the data. You see, when I joined Mayo Clinic's faculty in 2000, I immediately rejected the if in doubt, kick them out posture that guided the universe. And instead, I thought, why are we doing it this way? Why don't we do it, sports cardiology, this topic, the way we do basically all of medicine? And that is to respect patient and family autonomy and their right to make a well-informed decision. I believe that as the correct philosophy in 2000. I still embrace it as the right philosophy in 2024. But over these last 24 years, that philosophy has been buttressed by data. And we felt an obligation, if we were going to swim upstream and be a contrarian, that we would need to monitor this very carefully of the athletes who I've returned to their sport of choice to make sure that that decision wasn't reckless, dangerous, inappropriate. And we've been reporting this all along the way. We started with this initial cohort in 2012. So my practice from 2000 to say 2010, my first 353 patients with long QT syndrome from those ages. And one of the things I need to just clarify, I don't see only athletes. In fact, most of my patients are not athletes, and that's okay. If you are not an athlete when you come to see me, I'm not going to try to make you an athlete, but our focus is on the athletes. And I do see a lot of athletes, and this was our experience with the first 157 athletes. Now, among them, the myth that we busted, the fake news that we corrected immediately goes something like this. We cannot let the athlete and their family participate in that decision because they will always choose to be an athlete. Fake news, not true. We saw that immediately, and we're continuing to see that among my athletes, then and now, about 1 in 6, 1 out of 7 families where the primary purpose where they came, previously disqualified, was to get requalified to participate in their sport. And after the drill, they, the family unit, chose disqualification. So disqualification within the family structure is definitely possible. Now, the majority go through everything, hear everything, understand everything, and say, I understand, I'm going to be an athlete. So what about these first 130 long QT athletes? This is a profile of their snapshot in time, and only to point out that the majority do not have an internal defibrillator. In fact, most patients with long QT syndrome, whether an athlete or an artist or an academic, do not need and should not receive a defibrillator. You've heard me say that before. And for these, guess what? Remember that 1A thing that we said we would offer patients with heart disease? Most patients don't come seeing me doing cricket. They do all kinds of other sports, and I let them keep doing what they love to do. And if you understand long QT syndrome, you actually see we have a group of patients primed for the possibility of long QT sport risk exposure, because most long QT events, or many, happen in pre-pubertal boys. And in fact, we have the version of long QT syndrome, flavor number 1, that we know, at least when you're undiagnosed and untreated, sports, adrenaline, excitement, exercise can be long QT triggering. So we have a cohort of patients where we should see breakthrough events during their sport. Well, what did we see and what did we report in the Journal of the American Medical Association now 10 plus years ago? Uno, 1 athlete, dose, 2 events, 650 athlete years. Were we surprised for him? Not really. He was 11 years old, LQT1, very long QT interval, did cardiac arrest in kindergarten, and he went on and had 2 VF terminating ICD shocks during 2 of his sports, soccer and baseball. Really cool follow-up. I just saw him about a month ago. He's 28 or so, and he's working at SpaceX or one of the engineering companies, and doing a great job. So that's his story. Now, remember, he's one of those 15% with a defibrillator. About this same time in 2012 territory, the guidelines also said, I don't care why you got a defibrillator. If you have a defibrillator, whatever reason, primary, secondary, whatever disease, doesn't matter. You, an ICD and an athlete, is oil and water. You cannot coexist. And somebody raised their hand back then and said, what? Who says that? Why are we saying that? And that somebody was Rachel Lampert, who's a real special friend. And even in 2006, she had the courage to query the ICD installers, the heart rhythm specialists, and half, even back then, did not agree with that black and white categorical defibrillator, you're done kind of conclusion. And she went on and partnered with our program and others to create what's called the ICD Sports Registry, which when she did it, it was sort of viewed as blasphemy. How can you have, there won't be anybody in that, because ICD and sports cannot coexist. And she proved the naysayers very wrong. And we published our experience a decade ago, almost 400 such athletes with an ICD, continuing to be an athlete, and not quite 3 years of follow-up initially reported. And of course, there's going to be shocks. Hopefully we can lessen the inappropriate shocks, and I think we have, but these athletes got a defibrillator, hopefully for a reason. And yes, there will be shocks. All of our genetic heart diseases, genetic and non-genetic, represented, and you can see long QT syndrome was the most common. Second place, HCM. Third place, ARVC. But importantly, zero evidence for more damage to the device or danger to the host. Those were the 2 prevailing ideas, that the defibrillator is going to get damaged, or you're putting that patient with a defibrillator in a dangerous environment. It's going to trigger episodes, calling the device into action, and potentially having sudden death. 0 deaths, 0 evidence for increased damage to the device. We followed up on this, and with more follow-up, almost 4 years and over 1,400 athlete years of observation, you see 3%, about a 3% chance per year of an ICD shock in our athletes with their defibrillator. Now, we've updated our experience because we felt we're going to start having more and more athletes coming, and we did. And this update is from my former PhD student, Carrie Turkowski, now on staff with Mayo Clinic platform. And she looked at then my 322 athletes of mine, 259 with long QT syndrome. And so you start to see a growing number of called, my heart condition is something other than long QT syndrome. What's the update? We went from one athlete, to 9. 9 of these athletes having a non-lethal cardiac event in nearly 1,000 athlete years of follow-up. Event rate, about one event per 100 athlete years, or a 1% chance per year. And what really interesting of what Carrie found is shown here. Guess who has fewer disease-triggered breakthrough cardiac events? The athletes or the former athletes, the no longer athletes? The athletes have less events. And we could figure out and predict or speculate why that might be. I think I know the why. They want to stay an athlete. They do not want a breakthrough event because they know a breakthrough event will cause a penalty box phenomenon, a review of everything. The family unit will need to review again. The physician will need to review again. Are we all on the same page? Does this make sense? I don't want that to happen, so I'm going to sleep right, eat right, stay well hydrated, take my medication. And then this is continued with a 20-year examination of my 2 decades so far, thanks to Marissa and especially Kate Tolbert shown here. Both of these young women did their gap years in my lab and are now medical students in Milwaukee. Very proud of these 2 young women. But Katie Tolbert led the way, looking at 20 years worth of my patients, over 4,000 patients of mine, 567 long QT athletes. And the punchline now is 46 of them out of 672 athletes of mine, 29 out of nearly 500 with long QT syndrome. This percentage of them have experienced a non-lethal cardiac event in over 1,500 combined athlete years of follow-up. We're starting to get event rates collectively. So all of my athletes, if you come taken care of by me at Mayo Clinic, you have a 1.69 event rate per 100 years. So about, let's say, a 1.7% chance per year, roughly, for an athlete with a genetic heart disease to have an event, a breakthrough faint, seizure, cardiac arrest, ICD shock, or death, except the or death remains at 0. We're starting to get sport type event rates, although even with more athletes than probably anywhere in the world being followed, they start to splinter, don't they? And really nothing is separating as to which box, 1A versus 3C, is more dangerous than another box. Really not seeing that. We are seeing disease-specific rates emerging, although not reaching statistical significance yet. The lowest event rate is among my diagnosed and treated long QT patients, about a 1% per year. 2% per year if you're called CPVT and you see HCM. And 0 deaths in 23 years of our athletes returning to their sport of choice. Now, that will not stay 0 forever, and I'm very conscious and aware of that. And I remember at one of the presentations I did in Cape Town, South Africa, a philosopher, an ethicist, she came up to me and after that talk a decade ago, she said, your approach is right, your philosophy is right, and when, not if, when you have your first death, please do not change your approach. Now, easy to say, hard to do, and I hope and pray that that 0 stays 0 indefinitely. Now, Kate Tolbert followed up on this last year, now 2 years ago, and we looked at the difference between my athletes who were treated with an ICD, 125 ICD owners, versus the 533 who are being treated without the need of an ICD. And I think you see something pretty what I would hope you would expect, those who have an ICD have more events. That's because I put the ICD in. I did. Dr. Brian Cannon, one of my ICD partners, did. But we recommended an ICD because we felt their disease was ICD worthy, whether they were an athlete or an artist, meaning I don't put an ICD in ever to allow or enable you to do your sport. I put an ICD in because I think your disease requires it, needs it. The forecast risk is suggesting it, independent of whether you're going to continue to be an athlete or not. That's actually quite important. And when you do it that way, you see many more events, 6% per year, or 6 events per 100 athlete years of follow-up, compared to 0.3, a 20-fold relative risk difference. And look at how extreme it gets in long QT syndrome. 0.2 events per 100 years compared to almost 7. They got their defibrillator for a reason. Their substrate is twitchier. We're not as confident in their non-ICD protection. And you start to see this differential with the ICD, but still 0 deaths in the ICD positive athletes, 0 evidence of excess damage to the device, just like we're seeing in the ICD registry at large. But then you might ask, yeah, but what kind of athletes do you have? Are these just those little leaguers that you were talking about, pre-pubertal, maybe some high school, but are they elite? Can you get to be an elite athlete with a genetic heart disease? And in a way, that's not a fair question, because if you think about it, the community of heart rhythm specialists, cardiologists, adult and pediatric, have been pretty much universal disqualifiers for so long that it's hard to get elite at it when you've been told you can't get off the couch. And so it will take time for athletes who've been enabled to return to sport, or even think of doing sport at age 5, 6, 7, to have the opportunity to get good enough at their craft to become elite. So, but we did look at that, because among these 600 patients or so, I do have some elite. In fact, I have about 40 elites. Now, what do we define elite as? Division I university athlete or a professional level athlete. Now, this was a fun study that we looked back retrospectively, because we combined my 40 with the other balance, 36 or so, from these other sports cardiology programs. Did this with Kate Martinez and her father, Matthew Martinez. Kate's been in my lab as a GAP student for a year, 2 years now. And exciting news, just today, Kate got her acceptance letter to be the next Mayo Clinic Alex School of Medicine's MD PhD student starting this summer. So super proud of Kate. And this project, I was enabled for this to be one of those wonderful Martinez the daughter, Martinez the father, first and last author experiences. And so we combined my elite athletes with those from Dr. Bagish's program. You saw him with that origination of shared decision making that he and I and Rachel Lampert introduced in 2016. Kate's dad in New Jersey and Dr. Phelan in the Carolinas. And what did we find? We had 76 elite athletes who have one of these thingamabobs, a sudden cardiac death predisposing CV condition. 49 were a Division I athlete, 27 a professional athlete, and not surprisingly, nearly 2/3 were asymptomatic prior to diagnosis. Maybe their Division I university pre-participation screen that flagged them, found them, as opposed to, remember, you can't have been found 10, 15 years ago, because if you were, you would have been disqualified and given no chance to be elite. So this makes sense. And notably, 3/4 of them were disqualified at St. Elsewhere before they came to one of our programs and had their return to play facilitated. And yes, 1 out of 7 of all my athletes choose disqualification, but not when you made it to this level. Not surprisingly, that the vast majority choose to return to play. But we even saw some dropouts, as in self-disqualification, even at the elite level. And the follow-up. 3 of these elite athletes had one or more non-lethal breakthrough cardiac event, fainting, seizure, cardiac arrest, or an ICD shock, not death, following their return to play in over 200 athlete years of follow-up. Notably and importantly, 4 of the athletes, 5%, have remained disqualified despite our return to play approval, which is very important. While we can facilitate the return to play in the little leagues, in the middle school, almost always in high school, even Division II, Division III sports, not true at the Division I level or the professional ranks. In other words, shared decision-making ends at that level, and it gets replaced with something called the third party, or TDM, their decision-making. I think that's important to ready a family and the athlete for that it may not go smoothly at the D1 level. They have no obligation to agree with our return to play support and say, oh, sure, come on in. It will depend on their assessment, and we have to respect the university, the NFL, the NBA, the team, the owner, their right for their structure to make their independent, autonomous decision about the appropriateness of that athlete with genetic heart disease playing on their team, just like they're making their decision about that athlete who had reconstructive knee surgery to come back on their team. It's their right to do that. We have to ready these families for that. We never used to have to even think about that, because in the past, the answer was just say no. If in doubt, kick you out. And so I return to this and wonder where you might be in your thinking about this topic. And if you're close to a maybe or a yes and ready to leave, if in doubt, kick them out, law of the land, which the guidelines did leave, and embrace respecting patient family autonomy and their right to make a well-informed decision, I'm going to now leave you with 6 critical caveats and then 5 final take-home points to launch us into the conversation. So in the remaining 5 minutes of the monologue, critical caveat number 1, am I the right person to be doing this? It is now shifted to who is the informer helping them make a well-informed decision. It is okay to refer. It is not okay to spontaneously disqualify anymore. Am I the right person to be doing this? Second, if the athlete is a minor, the athlete and their parents must be in agreement. We call it the one veto vote is disqualifying. The family unit must be on the same page. Third, there can be no covert operations. The appropriate coaches, school officials must be informed. The athlete and their family says, can we just keep this down on the down low? Don't tell the school, don't tell the coach. Nope, they won't get my support for return to play. No covert operations. Fourth, the athlete must have their automatic external defibrillator, AED, as part of their sports safety gear. Now, I require that even though in 23 years, the number of AED rescue shocks among my athletes has remained 0. But it is my Boy Scout Be Prepared strategy, just like an athlete with a life-threatening peanut allergy, they need to have their EpiPen. My athletes need to have their AED. 5, there is no such thing, as I introduced with the elite athlete section, as shared decision-making at that level. It will be TDM, their decision-making, or BDM, business decision-making, and they need to go proceed with their recruitments with eyes wide open. And then 6, for the most, I don't know if it's the most important caveat, but it's an important one, document. This is a non-zero risk proposition, and even though we've been blessed with protection, 0 deaths in 23 years, I am not naive to think that we have a 0 risk lay of the land. I've discussed with the athlete and their parents. I've answered all their questions. They are proceeding with eyes wide open. They know there's no such thing as 0 risk. They know that even with a readily available AED, he or she could die suddenly. Document. Those are the 6 critical caveats. And with that, let me leave you with 5 take-home points for return to play for these type of athletes. First, I hope I've shown you that philosophy and art has trumped science and evidence as the underpinnings of the past sports participation guidelines. So when we were under this, if in doubt, kick them out, we were being more artistic with our recommendation than we were scientific. Second, shared decision-making works even in sports cardiology. Athletes and their families, they're fully capable to choose disqualification. So don't buy in to that myth. Let's hopefully have that fake news challenge. Third, among those who chose to remain an athlete, as I've showed you, the data, their disease-triggered event rates have been extremely low. Sudden cardiac deaths have remained zero for the past 23 plus years here at Mayo Clinic. Fourth, whether it's here at Mayo Clinic or throughout the world with our ICD sports registry, athletes and a defibrillator, if necessary, can coexist. Increased damage to the device or danger to the host is simply not there. And fifth and finally, and I think this is so exciting as to the future and the encouragement and the hope that we get to provide for our children, adolescents, young adults, is now athletes who get diagnosed in 2024 with a sudden cardiac death predisposing genetic heart disease, they can now be limited by the other D's: drive, desire, discipline, devotion, dedication, and not by their diagnosis. To me, that is great news. And with that news, I'd like to introduce you to ORCA and invite you, if you have an athlete at the collegiate level, professional level, who has any cardiac condition, genetic or non-genetic, connect them to this study that we've started nationally and soon to be globally, the Outcomes Registry for Cardiac Conditions in Athletes. There's the site that you can connect to. And I want to thank those entities that have partnered with our program, have provided the fuel for our program, especially the philanthropic support from Wendy's family that have helped us heal the sick and advance the science. And not related directly to sports cardiology, but if you're a health care provider and you're intrigued about genetic cardiology, I'd like to personally invite you to join us at Mayo Clinic's 8th genetic cardiology course, December 12th through 14th this year, at a really beautiful resort in Puerto Rico. It'll be our first time there for Mayo Clinic, and you're going to love it, and we will provide you an amazing course. But in the meantime, thanks for joining us tonight or whenever you're watching this. And now we're going to shift from the end of the monologue at 30 minutes on my counter and 25 minutes for our conversation together. And I will stop share and thank you very much, and look at our chat, and you can raise your hand or do a shout out, and I will look here, and I have one already in the queue from Dr. Merrick from Chicago. And I don't know if he's on to share it or just posted it. So
I think he posted it in advance for us.
So I will read it. And we have a 19-year-old female, asymptomatic, no family history, screening ECG, QTC 480, year-round athlete, trained 6 hours per week. Longest QT was screening with that number, QTC in recovery, that number, gene negative. Would you allow her to open water, swim, rock climb, outdoor scuba dive? So I think this is a beautiful question to start. I think with the question like this, we have to first figure out, does this person even have long QT syndrome? And in the past, we would say, of course she does. Her QTC is beyond the 99th percentile. But we had this observation in our program quite a while ago, got beat by my dear friend Peter Schwartz with the actual publication. But we were seeing all these disqualified athletes. And so their screening ECG was just like this. Then I would see them 3-6 months later in a state of disqualification, and their QTC was like completely normal, genetic test negative. And then Peter Schwartz and Leah Crotty publish and show this phenomenon of how athletic training, endurance training, can result in a maladaptive response to the repolarization of the heart, just like There is the athlete heart from a hemodynamic standpoint. There is some electrical remodeling that occurs. And so when you already have a negative genetic test and you know there's an athlete, now in their program, they call for detraining, which is not friendly to do to athletes. And if the QTC properties normalize to view this as sort of athlete or training associated repolarization reaction or reactivity. And I do not restrict them. If I call that QT an athletic, a training response rather than an underlying substrate, I do not restrict. So I would do an ECG on the first degree relatives, even with the negative genetic test. And if family ECGs are negative, stories negative, genetic test is negative, it sure is feeling like this is not even long QT syndrome. And if it's not long QT syndrome, then it doesn't warrant any type of restrictions. Perhaps maybe QT preventative measures, like let's avoid adding to the mix QT prolonging drugs. Jody has one for me about my thoughts about public automatic external defibrillator at sports practices, games, rather than a personal one. Would you still clear them to play with shared decision making? I love the question, Jody. I don't. I feel a family unit ought to take on the ownership of a personal AED rather than relying on a sports one located somewhere in the gym where they may or may not have the key to unlock it and so forth. So I just think my athletes, they need to take the onus to get their safety gear, just like I took the onus to get my fire extinguisher in our house and things like that. And now, will I return them to play while they're securing their AED, knowing that the school system has one and their team physician or trainer says, well, we have them? I do, because again, I think this is really for the long haul of being prepared. But in general, I make it an expectation that you do follow caveat number 4, which is to have your own AED as part of your own personal safety gear. Just like I don't think asthmatics athletes should use somebody else's inhaler that is locked up in the drawer. It's not the same analogy, but the principle is the same. Love that question. Other shout out ones, if I see a hand raised, we'll let you unmute yourself, or you can type it in the chat. You're welcome. And I do see of the names listed, I'm going to give a shout out to a great guy, Nolan, and his mom and dad, Brooke and Matt, who is recovering from surgery on Monday to begin then his journey to return to play. So after treated, after recovered, then we return to full competitive sports. So proud of this young man and his courage, and see you tomorrow, Nolan. Others, let's see, somebody has to have something they're gonna wonder about. Remember, all questions are appropriate. None are to be shunned or scorned. Anna, thanks, Anna. Oh, good to see you. Well, to see your name. How do you approach sports participation while you are evaluating an athlete for genetic heart disease but not confirmed? Ooh, good one. I think it depends on the portal of entry of that athlete. And the reason why I like this question a lot is I think we need to communicate out there the concept of what I call the penalty box. And we need to have, for worrisome syncope as the portal of entry, a concussion-like protocol. Meaning you can't get concussed on Friday, head concussion, and think that you're going to go to practice on Saturday, the next day. You can't have an unexplained, concerning, exercise-triggered faint on Friday night football and then think you're going to go to practice on Monday. You are in the penalty box. You are in the penalty box for as long as it takes for me or the healthcare world to establish the why, make the diagnosis, assess the risk, what is the forecast, dial in the therapy, be satisfied with the therapy, and then reintroduce you. So symptomatic, you are in the penalty box. I think asymptomatic, and now we're screening the family, and now a positive genetic test has emerged, and we're doing cascade testing, and the people we're testing are completely asymptomatic. You've already done the ECG in case of long QT. QTC is unimpressive. You've already done the echo in case of HCM, wall thickness is normal. Then I'm getting them reinstated a lot faster. I'm not putting them in the penalty box while their 2-week genetic test is waiting to come back and things. So I think, Anna, it kind of depends on how did that athlete come to our attention? Was it an incidental screen, or was it they just we're trying to get them in urgently because there just was a concerning faint mid-stride during the 100-meter dash or the 200-meter butterfly or things of that nature. Joel's asking a practical question. I appreciate that, Dr. Harnick. If a family wants to meet with me, and it would be a privilege, I would love to do that. How can they do that? And do we do telemedicine consultations? I think that was one of the beauties, wasn't it, Joel, when we had the COVID-19 pandemic? If there was anything good that came out of the COVID-19 pandemic, it was sort of the abolishment of practicing across state lines, and allowed us to do that first visit virtually. And so I established a pretty extensive video consultative practice. Well, that emergency pandemic declaration was ruled over, which then means that now our first engagement can only be done in states where we are licensed. So for myself, I have a license to practice in Minnesota, Arizona, and Florida, the 3 states where we have major Mayo Clinic presence. And then after that, and so if it's a patient from those states, I can do the first consultation by telemedicine. If they're outside those states, then the first one has to be in person. At least now, hopefully that rule, which is a stupid rule, I must say, will get changed to allow patients and families the freedom for that telemedicine visit anywhere. But for the other, let's see, 50 minus 3, 47 states, they have to start with an in-person evaluation. And they can do that. Erlene, my boss, her contact number for appointments to the Winland Smith Rice program is 507-284-0101. Or you can text me or email me and I can loop her in, but I would be delighted to partner with you or anybody who would like an assessment for their patient. So thanks for that one. What is the role of left cardiac sympathetic denervation in return to play? Well, I would put it nothing to do with return to play. In fact, every therapy we start with is disease-tailored therapy, kind of sport independent. But then what comes into play is quality of life, doesn't it? And the quality of life assessment for that person who says, I want to be an athlete and I hate how I feel on beta blocker, long QT, CPVT, and then denervation as a way to have a reduced beta blocker exposure strategy or potentially a no beta blocker strategy. Or if we think athlete, artist, academic, that the disease needs denervation, whether they like their beta blocker or not, we add denervation as triple therapy, double therapy. So we start with, do we think the disease needs all of the layers of therapy? And let's say I think all the disease needs is a beta blocker. We start the beta blocker. But then they say, thank you very little. You took me from an asymptomatic state for 20 years. And now you gave me a new symptom called, I feel lousy every day on my treatment, my beta blocker. Thank you very little. Well, in that case, we haven't done any good, and we have to be willing to do person-specific tailoring of their therapy, not just for the disease, but for their quality of life. And so I think those are some of the decision points as to whether they'll want return to play. Are we seeing more complications with denervation? No, not at all. I think what has happened with the denervation is The droopy left eyelid in our program, we've done one eyelid lift in our first 500 denervations. We never put in a chest tube preemptively. The number of patients who needed a transient chest tube for a surgery-introduced lung leak is 3%. So programs that do chest tubes in everybody, that's ridiculous. We almost never need it. The post-denervation neuropathic pain is the one complication that I probably respect the most, or wish I could have the antidote for. And it's held me back a little bit from putting denervation out there too aggressively as solo therapy. Although I think in the right patient population, it's right. Now, the denervation thing has gotten a little bit over exaggerated in 24/7 Google world, social world, connectivity world, because those denervated patients of mine, athletes of mine who are loving life, delighted that they're not on beta blocker, they're not on Instagram or Facebook or whatever. They're busy back to sport. The very few where the denervation has given them awful neuropathic pain, some of them have become very louder in the echo chamber of the internet space. So it's given, I think, an appearance that there's more complications, but there's not. Our collective significant neuropathic pain is probably 5 to 10% max. And that post-denervation neuropathic pain, that 5 to 10%, is overrepresented by the 20 to 40-year-old females, say, who really struggled with a variety of pain sensitization phenomena throughout their life, fibromyalgia, chronic fatigue, and so forth. So if they come in with that constitution, they're much more likely to be the individual who experiences the post-denervation neuropathic pain. But we're working on strategies to try to even lessen that, even in perhaps a phenotype predisposed group of individuals. But overall, as we published in a quality of life study, when we did, and in New Zealand, they did the same observation. And when you ask the patients and their families, everything you know, the way you felt before denervation and the way you feel after denervation, would you do it all over again? And I think it was something like 93%, 94% said absolutely. And that's pretty high when for a good number of those were elective surgeries. It wasn't because the disease had been so malignant, so spooky, so arrhythmic that they really didn't have a choice. So on balance, still very pleased. It is a boutique surgery. It needs to be done by a boutique operator. And so if they're not skilled at that surgical strategy, just like surgical myectomy for HCM should not be done by every cardiac surgeon, the same holds for videoscopic denervation surgery. Great question. Others, we have 8 minutes, I see, on the official counter before Marcia says time up. And Marcia's doing an early thank you with her choice. That's the final call for questions.
Nice.
All right. If there are no further questions, on behalf of Marcia, the education czar for the SADS Foundation, and Alice, who just popped in. Alice is our CEO. She's the boss of it. We thank you for joining us now, or if you're watching this tomorrow on whatever media platform that it will be presented. I hope you've derived some value with this. If I can help you in any meaningful way with any of your athletes, it would be my privilege. If the SADS Foundation can help you have a place of support, a resource of advocacy, connections for your families, whether they're an athlete or not, we take everybody at the SADS Foundation. We would be delighted as a nonprofit advocacy organization to partner with you. And if you derive personal benefit from it and you wanted to say thanks in a financial way, go to the SADS Foundation, www.sads.org, And you'll find on the front page, top right corner, I think it's still located. It says donate or donate now. Feel free to do that. And we would just thank you in advance for that expression of your appreciation for this webinar. So until our next time together, thank you so much. Blessings, everyone.
Thank you very much, Dr. Ackerman. We appreciate you sharing your expertise and volunteering your time tonight. And thank you all for joining us. So good night.
It was great.